Really encouraging for me, particularly since Asham, that there's a lot of community talking going on, and there's energy building to go to tackle this, the challenges we have now, and to take advantage of the new science, new treatments, new information. AIDS councils, positive groups, etc., have been really picking up the ball. I'm very impressed. Interestingly, the state and territory governments are also seem to be coming on board. I attended their BBVSS, that's the meeting of all the state and territory bureaucrats, attended their meeting in November and presented this paper, and there was agreement around the table from every state and territory that they will set targets and link those targets to action. Now that's a big breakthrough. No one has wanted to touch targets for years, particularly in the national strategy. And a working group has been set up, chaired by Andrew Grulich, to try and work up those targets and gain agreement. The targets will be discussed on the 15th of March, and if agreement is reached, they will go to RMAC, which is the Health Ministers' Council, and be endorsed. So we do have momentum going, and New South Wales is particularly to be congratulated about leading this effort. Commonwealth government leadership has been practically non-existent, really disappointing. We are trying to get to Tanya Plibersek, the new minister, and let's hope we can, and hope that the Commonwealth can get on board. But it's going to happen anyway, I think, even without the Commonwealth. They'll be dragged kicking and screaming along. So, I've talked about the advances in the science, I've talked about the advances in treatment, and I've talked about the momentum that we have going here in Australia and about our commitments under the UN Declaration. When I put all of that together, I think we should set a new goal for Australia, for our future response, and that should be to achieve virtual elimination of transmission and any new AIDS diagnosis in this country by 2018. And that once achieving that, we should sustain it indefinitely. So through this goal, transmission would be reduced to the level of virtual elimination amongst the highest risk populations, and no person with HIV should or would progress to an AIDS diagnosis. So people may think I've gone mad, but I think it's quite justifiable. And it's not the first time I've been called mad anyway, so I can live with that. So if we were to go with an ambitious goal, something like that, what would we need to do to achieve it? And this is the conclusion of the talk. I want to take you through some of the actions, the targets and the timelines that I think we should consider to reach a new ambitious goal to essentially end AIDS. So the first thing we need to do is to set bold time-bound targets for the populations at higher risk and agree on a set of actions to reach them. This is absolutely in accord with what we've agreed to do under the UN Declaration. So the key targets would be, I think we can reduce sexual transmission of HIV amongst MSM by 80% by 2015. In San Francisco, didn't have it on that slide, it's already talking about 70%, and has actually achieved that in some of their studies, and so I think that's a reasonable study. Our rates of injecting drug use are low, and I think we should be able to achieve and sustain virtual elimination amongst injecting drug use. Now, it's interesting, and I'm just digressing here, when we came to the 2011 declaration, the Secretary-General prepared a report, which is his analysis of the state of HIV, and he proposed some quite bold targets. Now, in his report, he called for a target to eliminate injecting drug use infections around the world, a zero target. And a number of scientists have argued for that. I don't think that's feasible, but I do think we can get it down a lot, probably to around 50%. But I just wanted to say that some people are very optimistic about if we got injecting drug programs, empowerment of communities, needle and syringe programs, people on treatment, that we should be able to do very well in reducing HIV amongst injecting drug users. But anyway, I'm talking about Australia. Here we can achieve that. Again, we've got very low rates of HIV transmission amongst sex workers. Again, I think we can achieve and sustain virtual elimination. That should be the target. And the same with mother-to-child transmission. We haven't had any cases for a couple of years, and there's no reason why we should beyond some bizarre accident. So that's prevention. But linked to that, everything now is about prevention and treatment. They should no longer be talked about as separate entities. They are mutually reinforcing and important. We also need to get more people on treatment, and I'm proposing a target of 90%. Various studies, somewhat imperfect studies, suggest we have around 70% of people on treatment. But it could well be lower, could be higher. My humble guess is that it's a little bit lower than that. But we need to get people 90% at least by 2013 to have a chance of realising those goals. And getting people on treatment is obviously for their own benefit. It's also to assist the reduction of HIV infection in our communities. So, if we set those targets, those three I just mentioned, we come close to eliminating HIV by 2015, and then over the next couple of years up to 2018, I think we could fully realise the overall goal that I first mentioned. Now, we will need to think about additional targets for other populations in Australia. This is very consistent with the Declaration of Commitment on HIV. Every country will need its own additional targets for specific populations. I've just highlighted the three highest risk groups, which are universal, okay? But when we look at things like migrants, some coal communities, there's work to be done there. And we also can't forget the fact there are heterosexual people dealing with HIV, obviously Indigenous community. All these things must be maintained, perhaps expanded, new targets can be set. But the name of the game, quite frankly, to drive this down, to achieve these goals, is focusing on the populations at highest risk and where there is the most HIV. That has to be the priority. So what do we need to do to support those targets? I think we need new information campaigns for people living with HIV. Most people with HIV will not be aware of this new science, will not be aware of the new information about the health benefits of starting treatment earlier, and they will not be aware of the information, or the full information about the impact of treatment on preventing HIV. So there's a lot of work to be done there. We need some road shows, big community meetings, that sort of thing, as well as public information campaigns. We need to promote combination prevention. And so it's not just about taking pills, it's reinforcing the value, the critical importance of correct and consistent condom use, safe injecting practices, harm reduction, and we need to take full advantage of all the new things we can use to get messages out, like social media, mobile phones, etc. We've not, I believe, fully taken advantage of the new modes of communication that are out there. We particularly need information campaigns targeting MSM, HIV negative people at high risk, to explain these buzzwords. But in all our health promotion programs, no matter who they're targeting and where HIV has some relevance, they need to be updated to inform people about the new information about earlier treatment, earlier diagnosis, and reducing transmission. Now, there is not going to be extra money in all of this, or very, very little. You can really, I think, we have to realise that what we're going to have to do is use the money we have more efficiently. Some money is going to have to be reoriented. I'm sure we can't just claim that every dollar is well directed. There is obviously some money that's going to be ill-directed. So the first and foremost thing is to make sure we're spending the money wisely. If we've done that and still feel that there is critical new money required, then I think you mount the advocacy case. Obviously, I think the group that should put in the money is the Commonwealth, They promised $10 million for HIV prevention some years ago, and we've never seen a penny of it. So it's time for them to kick in. So that's probably the best place. We need to roll out HIV testing. We need much wider health provider initiated testing. We need rapid testing, particularly in my view in community settings. It's good that there's a pilot rapid testing trial going ahead in New South Wales. I'd like to see one in every major city and some regional centres, so that testing becomes part of everyday practice amongst particularly gay men and others at very high risk, and it's part of the furniture. That's what we have to make it. There are too many barriers, too many uncomfortabilities, if there is such a word, for testing as it is. I think we can do our own projects around PrEP, access studies, which provide PrEP in a very carefully controlled but still accessible way. And we should be starting to plan those studies right now and collecting the data, because we one day will need them to support our own applications for approval in Australia. We've got to do something about reducing disincentives to treatment, and again, there are major barriers here. Simply the financial burden of going on treatment, where you have co-payments, is crippling. And I don't mean just for people on benefits, I mean for people with lower incomes, and even people with middle incomes who have a lot of dependents. It's a real barrier. And we've also got to overcome the Byzantine dispensing arrangements, where everyone has to go to a hospital to get their drugs. Now, again, there have been some good developments in New South Wales, and the Victorians have been doing some work, and I know it's a different picture around the country. But basically, we want to create a level playing field where these disincentives are removed. No use people going on treatment if they've got to choose between the treatment or paying the rent, etc. I think, as I mentioned earlier, we must get the information out about 052 to serodiscordant couples, particularly heterosexuals, but I think also homosexual couples. And we need health professional education and information. I don't believe that all our health professionals are up to date. It would be unreasonable to expect them to be up to date, given that these new studies and these shifts have happened really quite quickly over a period of just about 9 months. Now, I just want to again make the point that if we almost achieved virtual elimination now amongst these key groups, like IVUs and sex workers, that does not mean we stop the effort. Indeed, we probably need to increase it. It's been critical in getting us to this point, and it's been critical in the future, so there must be absolutely no reduction of effort amongst those communities. Quite the contrary. And finally, none of this revolution that I've talked about is going to happen without community mobilisation. This is what got us to endorse safe sex in the 80s. This is what in community mobilisation is what got the drug system and clinical research system reformed to the benefit of all Australians in the early 90s. The community mobilisation got us to access all the new drugs in the mid-90s. And I think if we're going to make these fundamental changes, we do need to mobilise our community and bring them along with us and create, leadership and momentum to overcome what are some very significant barriers, particularly at the Commonwealth level. So finally, just ending on costs, as I mentioned, if we invest now, we're ultimately going to reduce costs. Costs are critical not only in Australia, but much more particularly globally. And I guess I want to leave us with the global picture, because we're part of all of that. Sorry. That's the US joke. Your health insurance only covers placebos.